Professor Chowdhury, distinguished guests, thank you for the opportunity to be back in Bangladesh again, this time for the fourth time. And I'm going to present an update on estrogen receptor positive breast cancer, focusing on more recent developments in the context of the historical estrogen receptor positive breast cancer paradigm. These are my disclosures. Now, we are going to talk about early stage and metastatic disease, but I'm going to focus on the early stage disease for the bulk of this talk. We know well that this is the majority of breast cancer patients with estrogen receptor positive, HER2 negative. I'm not going to be talking about the HER2 positive cases, and there is also the evolution of the HER2 low patient population. Although in the early stage breast cancer setting, we have not yet seen a change in treatment options for those with HER2 low disease, indicating an IHC 1+ or 2+ and HER2-ish negative. We also have estrogen receptor low positive, and that was mentioned by Professor Dizon earlier on, and I think this is important because patients can have a gap in the evidence. So if they have an estrogen receptor low of IHC 1 to 10%, they may not have been included in the trials of either triple negative or hormone receptor positive cancer. And therefore, we don't have excellent evidence to guide our treatment. But we do have some real-world data, and we see that there's an NCDB United States analysis from last year that was presented at ASCO, suggesting that there was an improvement in the survival probability with adjuvant endocrine therapy for those estrogen receptor low patients. So you could ask, is it the worst of worlds or is it the best of worlds? If we consider they may be candidates for neoadjuvant immunotherapy and they may be candidates for endocrine therapy, perhaps they've got additional targets and they can have improved outcomes. But those cancers do behave much more like the triple negative cancers rather than the endocrine sensitive, strongly estrogen receptor positive tumours. In terms of staging, we know this well. Lymph nodes and tumour size, as the AJCC TNM, really is the strongest prognostic factor. And I think that that is inadequate. However, many of the trials now still use as the primary eligibility criteria the AJCC tumour staging. There may be some molecular factors that are involved as well, but this is key to how these patients see their prognosis. The stage does not necessarily dictate cancer sensitivity to treatment, however. Prognosis in the estrogen receptor positive population, according to stage, is clearly differentiated, with increasing stage being associated with a higher relapse risk. Whilst the estrogen receptor positive breast cancer patients, as noted by the two top lines in this chart, have the best prognosis, because it is the largest group of patients, we are seeing more relapses and a substantial number of patients with metastatic disease as a result of these estrogen receptor positive primary cancers. Luminal A and luminal B differentiated on the basis of traditionally Ki-67, but also now with the PAM50 risk of recurrence score and intrinsic subtype. There is a long-term recurrence risk. We've seen from the earlier presentations the shorter-term recurrence risk associated with triple-negative cancer. In ER-positive breast cancer, it can come back decades later, and that is even the case for these ostensibly low-risk T1N0 primary cancers. There is the ongoing suppressive effect of endocrine therapy, and then there is tumour cell dormancy, where tumour cells may sit in the bone marrow or elsewhere and be activated by something that we don't quite well know. As you can see, those patients with a higher risk with the T2 node-positive cancers do have a substantial recurrence risk. Some data that I've not shown here is the recent Oxford overview showing that we have had improvements in our outcomes over the years, with improvement in reduction in mortality, reduction in breast cancer recurrence risk. And I think that this chart here is somewhat historical and that the true rates are lower. Determining recurrence risk, I've mentioned, comes down to tumour size, nodes, grade, and then we look at genomic risk. So genomic risk is certainly not available. It's actually not routinely available in Australia, apart from patients who self-fund a genomic test. And so that is a small minority. And we can take into account patients, everyone within certain categories, or we could look at the intermediate risk category, like in the TAILOR-X trial, or think about the high clinical risk in patients who have a clinical risk where you would say, okay, chemotherapy is required to give them the best outcomes in the adjuvant setting, but could we avoid it? Because many of those patients actually don't need chemotherapy, they just need endocrine therapy. And studies like the ADAPT trial from the West German study group do indicate that many of those patients have tumours that are very hormone sensitive. There's the Predict Online calculator, which takes into account those clinico-pathological factors, but does not take into account genomic risk in this Predict calculator, and that can be quite useful in determining the benefit of endocrine therapy and chemotherapy to have a shared decision-making approach. As I mentioned, there are many treatment sensitivity genomic tests. So TAILOR-X in the node-negative population, Responder in the node-positive population evaluated the 21 gene recurrence score, and that does have a predictive and prognostic role. Now, I differentiate between predictive and prognostic because if there's a test that shows a patient will have a worse outcome, but there's nothing that you can do about it to change that outcome, then that is prognostic. And that is the case with something like circulating tumour DNA, where we still don't have something that we can shift those patients' outcomes. I'm hopeful that we will, but not just yet. Whereas predictive means that we've got a test where we can apply that test and either give an additional treatment or potentially take away a treatment without that patient suffering as a result. MammaPrint was evaluated in the MindAct trial and has a probable predictive role. There's been some more work done in the MammaPrint testing, which gives an indication of which patients with ER-positive disease might benefit from neoadjuvant immunotherapy. PAM50 I've mentioned, and EndoPredict both have prognostic roles. So which patients should be given chemotherapy? I've alluded to this earlier, but ductal more so than lobular, luminal B more so than luminal A, lymph node positive, younger or premenopausal patients, and part of that is likely to be the impact of ovarian ablation on those patients, and those patients with a high genomic risk. So chemotherapy now may have less of a benefit in those premenopausal patients with very endocrine sensitive tumours. Now that we have the data from SOFT and TEXT indicating that we should give 5 years of endocrine suppression at a maximal level for those with higher risk disease. But chemotherapy does have a substantial benefit, and more so in the ER-positive patients with premenopausal breast cancers. Oncotype in the premenopausal, there is some challenges. So in TAILOR-X node negative, there may be a benefit in those intermediate risk patients. And so we need to use a nuance here. In the node positive, this has been interpreted to say that patients who have a lymph node positive cancer, who are premenopausal, less than 50 years of age, should receive chemotherapy. However, I don't think that's the case. I think that it means that we just don't have the right test yet to work out which patients can safely have chemotherapy omitted. Which chemotherapy? So the Oxford overview again from quite some years ago now indicates that anthracycline is better than no chemotherapy, anthracycline is better than CMF chemotherapy, and that taxane anthracycline is better than anthracycline alone. And there's incremental improvements. So it's a small amount each time, but it all adds up. In terms of the low-risk patients who are a chemotherapy candidate, 4 cycles of TC may be reasonable. Intermediate risk, you may go up to 6 cycles, and high risk or intermediate high risk with anthracycline taxane. There was some retrospective data from the TAILOR-X trial about the effect of chemotherapy and which chemotherapy to use in patients with a score of more than 31. Suggesting that there is an anthracycline benefit there that is predominantly restricted to the premenopausal patients again. I'm briefly mentioning neoadjuvant chemotherapy and immunotherapy. So there's the Keynote 756 and 7FL trials. Now this is not ready for prime time yet. There was an increase in the PCR rate, particularly in those patients with the ER low tumours, but there's still a difference in the patients with a more than 10% estrogen receptor expression. And we don't have event-free survival yet. Unfortunately, 7FL is not going to be powered for event-free survival either, but there's similar effects in the estrogen receptor low, mammoprint high 2 population, and those with high-grade tumours. I think that adjuvant zoledronic acid has a few advantages, and it's something that we've seen used variably. So 6 doses once every 6 months in patients who are postmenopausal, and it has a reduction in breast cancer mortality of a few percent, again, all incremental, but it's actually got the benefit of improving bone density, particularly for patients on an aromatase inhibitor. And we need to make sure that patients have good teeth because of the risk of osteonecrosis of the jaw, which can be quite nasty. The other end of the spectrum, for the lower risk, who can we not give endocrine therapy to? The St. Gallen panel of a couple of years ago looked at the size of the cancer of a primary lymph node negative cancer to work out who they would think would be reasonable to avoid endocrine therapy in estrogen receptor positive, luminal A or luminal B. And that around the 5 millimetre mark essentially was decided. However, again, I think that shared decision making is important here because patients do have a quality of life detriment as a result of this endocrine therapy. And for those patients with low risk cancer, 5 years would be routine. And to that end, the Europa trial has recently reported showing that in a comparison of either radiotherapy or endocrine therapy for patients with a T1N0 cancer, estrogen receptor more than 10%, age more than 70 years, that there was a detriment in quality of life, and the patients who had radiotherapy had stable quality of life, patients with endocrine therapy had reduced quality of life. Now, there is very limited follow-up data on breast cancer outcomes here, and so there's only a fraction of those patients who are reported in this study, and we need to await further outcomes to ensure that there is good oncological outcomes. But it does suggest that there's a group of patients who may be well served by radiotherapy alone. In the premenopausal patients, we know about the SOFT and TEXT trials, and they've demonstrated in long term a breast cancer recurrence improvement, and that's been shown in a meta-analysis which included a couple of other trials. But then when we look into which patients truly benefit from ovarian suppression, in addition to either tamoxifen or an aromatase inhibitor, it is more the patients with higher risk cancers. T2 or larger, so more than 2 centimetres, lymph node positive, the patients who were considered for chemotherapy, they're the ones who seem to benefit most. And there's a step analysis that was done by Meredith Reagan, and there's an online calculator which has somewhat convoluted URL that allows you to understand which patients might benefit most from ovarian suppression, plus or minus AI versus tamoxifen. In postmenopausal patients, between years 0 to 5, starting during or after radiotherapy or awaiting the trial that looked at that, the STARS study should report very soon. And it reduced breast cancer mortality and all-cause mortality with AI over tamoxifen. However, I think that the benefit is actually very small to aromatase inhibitor versus tamoxifen. And I don't use that as the one arbiter of what treatment they should start on, and then they often switch down the road in any case. It's based on toxicity profile, with AIs having fracture risk, arthralgia, versus the venous thromboembolic disease and endometrial pathology with tamoxifen. How long should these patients remain on endocrine therapy? The greatest benefit is really in the first 5 years, and probably for many patients in the first couple of years. There are many patients who stop due to toxicity, and then the decision is made. They just can't tolerate these treatments, and we do need better treatments. I suspect that the selective estrogen receptor degraders that are coming through in trials now for higher risk patients are actually a bit better tolerated, and I've got a couple of certain trials in the early stage setting running at the moment that patients do seem to tolerate quite well. Tamoxifen, 10 years is better for node positive and or T2 tumours. AI for 7 to 10 years in lymph node positive. And then I do sometimes use the Soleil approach, which is a 9-month on, 3-month off after the 5th year. And patients, particularly in the summer months, they like to take 3 months off their endocrine therapy, and there's no detriment to that. Indefinite therapy for the very, very high-risk patients, and I don't think we've got great evidence for it, but I do give some patients with heavily lymph node positive, ER-positive cancer indefinite endocrine therapy. And so this chart shows that I would suggest 7 or 8 years for those intermediate risk, 10 years for the highest risk, and 5 years for lymph node negative patients. There is a carryover effect after completion of endocrine therapy. And you can see here in this cumulative incidence curve, there are increasing separation. After 5 years of endocrine therapy with tamoxifen, patients benefit beyond that time and have a reduction in recurrence risk. And I suspect that much of this is going to be related to a reduction in new primary breast cancers. But those new primary breast cancers don't have a high mortality risk, but they do lead to additional treatments being discussed and the need for surgery, thinking about radiotherapy, and so forth. Fortunately, the toxicity resolves soon after endocrine therapy cessation, and that prevention role of endocrine therapy in avoiding new primary breast cancers, I think, is important to many people. The benefit of endocrine therapy increases with higher nodal burden. And on the left, we have lymph node negative with a small benefit of endocrine therapy extension beyond 5 years, and increasing up to a 7% difference with more or equal to 4 nodes. We've got an online score, which is quite simple, the CTS-5, that calculates the recurrence risk at distant sites between years 5 and 10 based on age, tumour size, lymph node burden, and grade. And that's accessible to anybody. So the CDK4/6 inhibitors, something that has been a major revolution in ER-positive breast cancer over the last few years, and now in the adjuvant setting with the Monarch-E trial. This was high-risk patients, 4+ nodes or 1 to 3 nodes, grade 3, or 5+ centimetres. 2 years of standard dose of abemaciclib, and we've seen an invasive disease-free survival benefit that's now increasing even after completion. So all those patients are now off abemaciclib, and there's still a benefit seen. We were worried that those curves might start to come together, indicating that it was just slowing things down and preventing relapse for a period of time, then all of those patients would relapse, but it's not the case, I don't think. Key 67 is prognostic but not predictive here, so not necessarily to be used for decisions about treatment. And it was stable across subgroups. The other major trial is the NATALY trial, and that's intermediate to high risk, stage 2A to 3 within 12 months of starting endocrine therapy, so they could have had a longer period of time before they started on ribociclib. It's at a lower dose, 400 milligrams daily, 3 weeks on, 1 week off, so it's a bit more of a complicated regimen for 3 years and with at least 5 years of a non-steroidal aromatase inhibitor, whereas with Monarch E, they could have had any aromatase inhibitor, or tamoxifen for that matter, but there's a concern around QT interval prolongation with the combination. There was an invasive disease-free survival benefit, and the update at 4 years indicates that that's around 5%. The hazard ratio is the same for both node positive and node negative, but that being said, the absolute benefit is a little smaller in those lymph node negative patients, and I think that we'd need to have other factors to consider those patients for adjuvant CDK4/6 inhibitor use. This is a chart comparing the eligibility of NATALY versus Monarch E, and you can see that there are patients only with higher risk features in the Monarch E cohort, but they were allowed to go on to NATALY. And so there's not a good predictive role for our conventional markers for who's going to benefit from these drugs. Toxicity is also important, and abemaciclib causes diarrhea, but it does seem to improve with dose reduction and with time and with good management. If you have to do a dose reduction, then there still appears to be a benefit to both of these treatments. There is the risk of VTE and pneumonitis, which are uncommon but do occur, and cytopenias with ribociclib, QTc as I mentioned, and increased transaminases. There are patients with ER-positive breast cancer who are BRCA gene carriers, and they are potential candidates for olaparib according to the Olympia trial, and they are the very high risk. So patients who have ER-positive 4 or more lymph nodes, and in the either neoadjuvant setting, an RCB score that's elevated, or at high risk anatomical staging. It was 18% of the Olympia population, but in that ER-positive group, there is an ongoing benefit, so 9.4% IDFS benefit. And there was low toxicity from this treatment. It does add additional cost and some additional effort. And there was a lower second primary malignancy rate, which I think is quite interesting from those Olympia patients. I think this might lead to an increased rate of testing for both ER-positive if they've got a family history, and lower that threshold. One issue, and I'm going to diverge a little bit into a surgical topic here, is about our common discussions in the MDT around how much lymph node surgery. We're seeing de-escalation in lymph node surgery, but that may mean that patients don't know how many lymph nodes are positive, and so they may not be a candidate for Olympia or Monarch E type treatment. And this has been an ongoing question that has been attempted to be answered by a couple of retrospective reviews. And if there's one lymph node positive with no axillary clearance, then it's unlikely that that will render a patient eligible if they were to have an axillary clearance. Whereas if they go up to 2 lymph nodes positive in a sentinel node biopsy and then don't have an axillary dissection, then they have about between a 15 to 25% chance of having upgrade of their lymph nodes and being eligible for the adjuvant CDK4/6 inhibitors. So I think that neoadjuvant immunotherapy is likely to come for highly selected patients, but certainly not all. Neoadjuvant endocrine therapy to determine sensitivity and avoid chemotherapy may well become important. Less chemotherapy using trials like the Optima trial, which is currently recruiting, and adaptive treatment, and less endocrine therapy is potentially an option for those at very low risk. The St Gallen guideline consensus is coming up in a couple of weeks' time, so keep your eye out for that. So briefly about metastatic disease. And so first-line treatment choices, well, standard would be CDK4/6 inhibitor plus endocrine therapy. And I picked out both so palbociclib here and abemaciclib and ribociclib. So I think in that first-line setting, they are all quite equivalent. However, there have been some retrospective studies and some real-world studies suggesting that abemaciclib and ribociclib are a little bit better than palbociclib, and that's borne through in the adjuvant data, which I didn't mention because the trials were negative. So it's actually better than chemotherapy to have endocrine therapy plus a CDK4/6 inhibitor for the vast majority of patients, even with visceral metastases with a moderately fast tempo of cancer. The benefits across subgroups. So the question here is, what should we do if a patient has endocrine sensitive disease in first line? Well, now we have the SONIA trial, and the SONIA trial indicates that there's no difference in progression-free survival and a minimal overall survival difference. It's not statistically significant if you delay the CDK4/6 inhibitor until the second line of endocrine therapy, assuming that they don't have any high-risk features. And so I think that that is something that is quite worthwhile considering, especially if resources are constrained. So Monarch 3 is the abemaciclib trial, median follow-up of 39 months, and there's an ongoing PFS benefit there, and PFS2 benefit also. That real-world comparison that I mentioned earlier, with an overall survival of 67 months, which is quite impressive for patients with a diagnosis of metastatic disease. And this is the chart from SONIA of PFS2, and there's a slight numerical improvement in PFS2, but the overall survival was no different. So this has stirred up a bit of controversy, I'd have to say. Adding in agents, so we traditionally have used sequential single agents. Now we're adding more and more, and we've got the Inavo 120 using inavolisib for PIK3CA mutated HER2 negative hormone receptor positive breast cancer, but it was higher risk, recurred within 12 months of endocrine therapy in the adjuvant setting or on that treatment. But it did show that the triplet therapy of the PIK3CA, palbo, plus fulvestrant was advantageous. Beyond that, we've got some targeted therapies, so alpelisib or inavolisib, ipatasertib, exemestane and everolimus remains a worthwhile treatment strategy. And then the retreatment with abemaciclib with an imlunestrant backbone with EMBA3 I thought was quite interesting as well. Emerald showing elacestrant with an ESR1 mutation is advantageous. And then we move on to chemotherapy beyond that first and second line. So ER positive, HER2 low, there's TDXD. I think capecitabine is a really worthwhile treatment, especially in lobular cancer, and you can consider the X77 regimen as well, with 1500 milligrams flat dose, 7 days on, 7 days off, which seem to be better tolerated. Eribulin, sacituzumab govitecan, according to the TROPiCS-02 trial, and then there's a range of others. We've mentioned DESTINY-Breast04. This is the ER positive group, and there was a substantial PFS benefit of 10 months. So think about endocrine sensitivity in metastatic estrogen receptor positive breast cancer. In the second line, ESR1 mutations can predict the benefit of a further SERD, and PIK3 inhibitors, AKT inhibitors, followed by sequential single-agent chemotherapy. And surgery is not something that we would generally do unless there's isolated progression. So thank you for your attention, and I look forward to the rest of the meeting.